Paget's disease of bone. Paget's disease of bone is characterized by focal areas of increased and disorganized bone remodeling involving one or more skeletal sites. The disease is common in the UK, affecting about 1% of those aged above 55, and in other countries in Europe. It is rare in Scandinavia, the Indian subcontinent, and the rest of Asia. The prevalence doubles each decade from the age of 50 onwards and affects up to 8% of the UK population by the age of 85. Pathophysiology. The primary abnormality is increased osteoclastic bone resorption, accompanied by marrow fibrosis, increased vascularity of bone, and increased but disorganized bone formation. Osteoclasts in Paget PDB are greater in number and unusually large, containing characteristic nuclear inclusion bodies. Genetic factors are important, and mutations in the SQSTM1 gene are a common cause of classical Paget's disease. The presence of nuclear inclusion bodies in osteoclasts has fueled speculation that Paget's disease might be caused by a slow virus infection, but this is unproven. Biomechanical factors may influence which bones are affected, as Paget's disease often starts at sites of muscle insertions into bone and in some cases localizes to bones or limbs that have been subjected to repetitive trauma or overuse. Involvement of subchondral bone can compromise the joint and predispose to osteoarthritis. The prevalence of Paget's disease of bone has fallen in many countries over recent decades, suggesting that environmental factors play a role, but the identity of these triggers remains unclear. Clinical features. The axial skeleton is predominantly affected, and common sites of involvement are the pelvis, femur, tibia, lumbar spine, skull, and scapula. The most common presentation is with bone pain localized to an affected site, but bone deformity, deafness, and pathological fractures may also be presenting features. Many patients are asymptomatic, and the diagnosis is frequently made on the basis of an X-ray or blood test performed for another reason. Clinical signs include bone deformity and expansion and increased warmth over an affected bone. Neurological problems such as deafness, cranial nerve defects, nerve root pain, spinal cord compression, and spinal stenosis may occur due to enlargement of affected bones and encroachment on the spinal cord and nerve foramina. Surprisingly, deafness seldom results from compression of the auditory nerve but is conductive due to osteosclerosis of the temporal bone. The increased vascularity of pagetic bone can rarely precipitate high output cardiac failure in elderly patients with limited cardiac reserve. Osteosarcoma is an unusual but serious complication that presents with increasing pain and swelling of an affected site. Investigations. The characteristic features are an isolated elevation in alkaline phosphatase and bone expansion on X-rays, with alternating areas of radiolucency and osteosclerosis. Levels of alkaline phosphatase can be normal if only a single bone is affected. The best way of identifying affected sites is a radionuclide bone scan, which shows increased uptake in affected bones. If the bone scan is positive, X-rays should be taken to confirm the diagnosis. Bone biopsy is not usually required but may help to exclude osteosclerotic metastasis in cases of diagnostic uncertainty. Now, management. The main indication for treatment with inhibitors of bone resorption is bone pain, which is thought to be due to increased metabolic activity. Patients should be carefully assessed to determine the cause of the pain, since it can be difficult to differentiate the pain caused by increased metabolic activity of Paget's disease from that caused by complications such as bone deformity, nerve compression symptoms, and osteoarthritis. The bisphosphonates, pamidronate, risedronate, and zoledronic acid are highly effective at suppressing the elevations in bone turnover that are characteristic of Paget's disease, and also improve bone pain that is caused by increased metabolic activity. If there is doubt about whether the pain is due to Paget's disease, it can be worthwhile giving a therapeutic trial of bisphosphonate to determine whether the symptoms improve. A positive response indicates that the pain was due to increased metabolic activity. There is no evidence as yet to suggest that bisphosphonates prevent the development of complications in Paget's disease. Repeated courses of bisphosphonates can be given if symptoms recur. Now, figure 24.63 shows Paget's disease. The A figure shows 99 technetium leveled bisphosphonate scintigraphy from a patient with Paget's disease, illustrating the intense tracer uptake and deformity of the affected femur. B. The typical radiographic features with expansion of the femur, alternating areas of osteosclerosis and radiolucency of the trochanter, and pseudofractures breaching the bone cortex arose. Figure 20 box 24.76 shows medical management of Paget's disease. Drug etidronate, route of administration oral, dose 400 mg daily for 3 to 6 months. Tiludronate, oral route of administration, dose 400 mg daily for 3 to 6 months. Risedronate, oral route of administration, 30 mg daily for 2 months. Pamidronate, IV, 1 to 3 into 60 mg infusions. Zoledronic acid IV, 1 into 5 mg infusion. Calcitonin subcutaneous, 100 to 200 international unit 3 times weekly for 2 to 3 months.